Well, today I'm going to talk to you a bit about hybrid trials. So how we move from pragmatic trials to effectiveness implementation hybrid designs. I'm just trying to, okay, there we go. So I want to allow you to understand the difference between a pragmatic cluster randomized trial and a hybrid implementation effectiveness trial, review the concept of hybrid designs, the different types of hybrid designs, and very briefly understand how implementation science frameworks can be embedded within the different trial designs. And I say this because very often I find that people don't understand what to do with the frameworks once they learn the different frameworks and their different uses. So a bit of background, and I'm not sure how long many of you have been around for. When I started out, we had a lot of these pragmatic trials. You know, they're not efficacy trials, but they're pragmatic trials. And these were developed due to criticisms of efficacy trials in that they're not generalizable to real life. So we're developing this trial that's going to be more about real life. It's going to be more practical. We're going to understand how to scale it up. And people who developed this concept claimed they were generalizable to real life and how an intervention is going to work. But with the pragmatic trials, and there's a lot of literature on this that I can share with you if you like, they do not, depending on who conducts them, but a lot of people who use these, it doesn't really facilitate an understanding of how we can, a trial in one context could be generalized to a new context. Instead, it's usually a cluster randomized trial, if we're lucky, with a very good process evaluation. But since this, conception of pragmatic trials, we really moved on to understand how trials can be adapted to better suit implementation research. And this is where the effectiveness implementation hybrid designs come in. And this idea was conceptualized, I think, by someone by the name of Curran. It's an American professor. I think he's a sociologist, and he came up with the idea. And I think I've provided some references to the original paper, but he conceived the idea of these implementation effectiveness trials. And what these trials do is they blend the cluster randomized trial with a process evaluation to pure implementation designs. They used mixed methods, including those from implementation to science, to understand not only clinical effectiveness, but also for whom, how, and under what circumstances. And this is really important. Opening up the black box to understand how a complex intervention unfolds. And with these trials, context is really key. So we really have to understand how to adapt an evidence-based intervention and effectively implement it in a new context. And we refer this new intervention that's been adapted to an evidence-informed intervention because we're really not sure if it's going to be evidence-based yet. It's informed based on previous evidence. And the implementation science frameworks and theories and social science approaches can really help with this requirement. They're really key. It's really easy to do, not easy, but in comparison, a clinical trial is looking at clinical outcomes, the primary outcome, a few secondaries, that's pretty straightforward. But opening up that black box is a lot more complex. So I'm just going to review quickly a few implementation science concepts or methods used in hybrid trials. So first of all, we have context. And context, as I said, is super important. And if you look at the literature, there's 5 broad categories of context. So you have the external context that I find is really important in global mental health, an area that I really do a lot of work in. Then we have the context in the inner setting where the intervention is being delivered. We have the context of the implementation, the intervention itself. How complex is this intervention? Is it easy to use? Then we have the context of the users. So who are the users? What is their knowledge? What is their understanding? And then we have the context of the process of the implementation itself. So it's an incredibly important concept. It's very complex and it's often not addressed adequately. Implementation science determinant frameworks. These offer a theoretical approach to implementation research. And they're essentially a compilation of barriers and enablers and put in different domains that have been shown to influence the effectiveness of implementation efforts previously. A big barrier that I deal with my research is stigma. Now, moving on to implementation theories, this is the proposed generalizable explanation regarding how an intervention unfolds. They're a lot more complex. I was talking to a few people in the breakout room, and I would really suggest, you have a social scientist, which is something I'm not, if you really want to understand how you're going to use implementation theories within hybrid designs. Implementation strategies. I'm not sure if everyone remembers what this is after their training, but these are essentially the things you do to implement the evidence-informed intervention that you've adapted. Okay, you could use task shifting through health extension workers that we have in Ethiopia, for instance. And these are used to overcome the barrier of lack of skilled workforce due to a lack of resources. Another example of strategy is different training. Another strategy could be person with lived experience. So we deal a lot with this in the work that we do, really getting these people to come forward and really help to reduce the barrier of stigma in global mental health. Then we can move on to the evaluation frameworks, and I really like these because it helps me pick out different outcomes to evaluate the different strategies and the intervention itself. So how can we evaluate the effectiveness of task shifting? Picking different implementation outcomes to specifically address task shifting. And what's appropriate for task shifting? How do we evaluate as to whether the training is effective? And the implementation outcomes are embedded within the different evaluation frameworks. So I just wanted to briefly review those because I know people sometimes forget, and if you're not using them in everyday practice, you understand there might be a bit of a misunderstanding about how they can be applied. So if we look at a pragmatic and a hybrid trial, a pragmatic trial will be a purely clinical intervention on a drug, procedure, or therapy. So it might be cognitive behavioral therapy, for instance, and understand if that is equivalent to behavioral activation therapy or behavioral activation therapy equivalent to CBT. The primary outcome is health outcomes, and it's at the individual or patient level usually. A hybrid trial is a lot more interesting. It's a clinical intervention with different implementation strategies. The intervention is an adapted clinical intervention with implementation strategies. The focus is on, the degree of focus depends on the type of hybrid you're doing that we're going to discuss in a minute, but the focus is on implementation outcomes or clinical or health outcomes. And we usually randomize clusters within this. And we analyze clusters and patients depending on the type of trial that you do. So if we look at a diagram of where these types of trials fit, they kind of fit between effectiveness research and pure implementation research. So they're hybrid trials. And why do we do hybrid trials? Who's seen this diagram before? Good to know it's being widely used. Yeah, there's 17 years gap. And I expect it's a lot more, especially in low resourced settings. It's just super difficult to scale up these interventions. So these hybrid trials are designed to do this. The pragmatic trials, they're okay, but they're not as speedy as moving things from, effectiveness to full-blown implementation. And there's no reason to wait for perfect effectiveness data within a pragmatic trial. We can backfill this information when we test the different implementation strategies. So why are hybrid designs and why are they better than the pragmatic? So if we can compare clinical outcomes to to implementation outcomes that are measured at the individual level. So sometimes we collect information on acceptability, appropriateness, and feasibility at the individual level, or also fidelity at the individual level. And just doing a little ANOVA can tell you if they're associated or not. Importantly, we look how context influences not only implementation strategies on implementation outcomes, but also influences the intervention itself. And this can help us explain why the intervention was effective or not. And this is really important. So we can look at implementation outcomes on their own, but if we don't bring context into this, it's pretty useless, except other than to know it was acceptable or not. So the hybrid trials help us to open the black box. And they're applied, and you might have heard this before, in the pre-implementation, piloting, the implementation and evaluation, the post-implementation and dissemination. All these phases, sometimes they overlap, but they all serve a purpose, and the pre-implementation being super important, because often this phase is overlooked. We embed implementation science methods or social science methods throughout these different phases. So now we move on to hybrid trials, which is the point of this talk. And there are three main types of hybrid trials. And some of the definitions are quite loose, but I find there was a misunderstanding of some of the basic properties of the hybrid trials. And it's important that we get these right, especially when we say we're doing, say, a hybrid type 2 or a hybrid type 3. So we have the type 1 trial that's similar to a pragmatic, but there's more of a focus on context, and we do collect information on implementation outcomes, but we can look at context and how it influences implementation outcomes. The hybrid type 2 focuses on implementation and clinical outcomes, and a hybrid type 3 focuses on implementation outcomes. I see a little typo there. So here we go. Types of hybrids. Type 1, test the thing, so the intervention, observe and gather information on doing the thing. Type 2, test the thing, test and study doing the thing. And a hybrid type 3, test doing the thing and observe and gather information on the thing. So if we move on to the specifics of a hybrid type 1 trial, our primary objective is to look at the clinical effectiveness of the evidence-informed intervention that we've adapted. Our secondary aim is we look at the context of implementation. What are the barriers and enablers? What worked, what didn't work? How can we adapt the trial going forward? And it's usually a cluster randomized trial. When we have a type 1 trial, there has to be existing evidence for the clinical effectiveness in a different context, but not a similar context. And this is very important. We think that may be applicable in the relevant setting, the local setting. And so it's an ideal opportunity to use an effectiveness trial to explore implementation issues. And these have to be explored explicitly and explore further implementation strategies for the next phase. So if we think about the type 1 trials, many of the strategies used in a pragmatic trial are not feasible when we scale up. So a pragmatic trial might use nurses instead of community health workers, or they might hire someone specifically for the purpose of the trial. Okay, this is just not feasible when we start scaling up. And using things like task shifting in the type 1 hybrid are key, because we learn from these even if we're not measuring their effectiveness. So I would argue that using a paid worker in a hybrid type 1, just, that's not real world. What is the point of doing this? And I've seen some trials, and I was doing a secondary data analysis of one of the trials, and they had to use a nurse. So, you do what's feasible, and if possible, use someone who you'd be using in the real world setting. And that's very important. So how would we apply implementation science frameworks in the type 1 study? I'd use the determinant frameworks to develop topic guides to address context. So you're interested in context, not as explicitly as you are in, say, a type 2 hybrid, But you want to collect information. How is context playing out in this intervention? How is it influencing the effectiveness of our intervention? And I've seen some type 1 trials, and one I'm involved with in particular, that's more of a type 2 than a type 1. And this is becoming more commonplace. People are calling it a type 1, but it's a pretty robust hybrid trial that uses a lot of the same design features you have in a type 2 trial. There's still a little bit uncertain if it's the implementation or the intervention is going to be useful. In a type 1 trial, I would also evaluate for acceptability, appropriateness, feasibility, adaptability, and fidelity of the different implementation strategies. Maybe not as focused as in a type 2, but it's still really important to do this. And I'll give you some examples. Just let me see what the next slide is that we move into type 2. So I wanted to give you some examples of some type 1 trials that were really important. And there was one that was looking at, and I forget the specific name, and I'm going to have to look at this, but it was using corticosteroids in low and middle income countries. And it was a massive, massive trial. I think it took place in different countries. But they actually found that using the corticosteroids in pregnancy was quite harmful in this type 1 trial. So that's a good example of why that trial needed a type 1 study with a rigorous clinical outcome, but also looking at context and understanding why it wasn't possible. Why did the corticosteroids prove to be more harmful, and how can we possibly change this? I think it had to do with the cadre of worker not being trained well enough or not having the capacity, and delivering corticosteroids in pregnancy can be quite tricky. In whether it's possible to use without the involvement of a clinician is another story. So that's a good example of a type 1 study. So the type 2 studies, and this is really important, because with a type 2, we have a dual focus on clinical and implementation. And that basically says the implementation outcomes are equally as important as the clinical outcomes. You still power the trial for a clinical outcome. You can't power the trial for an implementation outcome when it's only measured in the intervention arm. Okay? Unless you're doing some type of quasi-experimental. But that's really important. It's an important feature. It's a dual focus with both of these. I tend to like a focus on adaptability or preferably fidelity for the implementation outcome, because that can really compromise effectiveness. So when do we do a type 2 trial? This can be done with this existing evidence in a similar context. So we might have one African country and we're moving to another African country, and we think it's probably going to work there. And a hybrid trial is actually a good excuse to collect as much evidence as possible. We're not sure of the clinical effectiveness in this context or population, so we're a bit uncertain about that. We have information on barriers and enablers, not a lot, but enough to understand that we think it probably will be okay. It might take a bit of tweaking. And there's some information on implementation strategies. So what makes this type of trial different from a type 1 trial? We explicitly describe the implementation strategy and explicitly describe the implementation outcome to measure that implementation strategy. If I was reviewing a paper or a study, I'd want to see that. I'd want to see that incorporated into the trial design. Explicitly measure adoption and fidelity. This is super important here, okay? Because if these two get compromised, it's going to influence the effectiveness of your intervention. We also want to make clear the intervention components versus the implementation strategy, and it isn't always clear. I see an implementation strategy as something to facilitate the implementation, improve the adaptation. So I've given 2 examples here. If an intervention is delivered over the telephone, is it an intervention component or an implementation strategy? I would see that as an implementation strategy because it's used to facilitate the delivery of the intervention. So I'm involved with some behavioral activation trials, and some of these are known as stepped care. So they offer extra sessions if there's not an early response. I see that as a component of the intervention. Other design considerations, again, I know I'm banging on about this, but it's really important. Adoption and poor fidelity, the effectiveness gets compromised. So how can we improve this? We look for implementation strategies with a relevant evidence base. So we have a good idea they're going to work. We're going to explicitly monitor for adoption and fidelity to see if they're working as they intended. We're going to look at how context might influence the fidelity. And fidelity, by the way, is a pretty complex implementation outcome. But I will leave that for another time, other than to say I think there's 5 broad categories of fidelity. So the 3 main ones that I usually consider: the fidelity of delivery. So was the training delivered as intended? Were the sessions delivered as intended? And then you have fidelity of receipt. Do people attend the sessions? And then you have fidelity of enactment. Did they do the homework associated with the session? So it's important to capture all of those. So again, if we use implementation science frameworks, I would use them in a similar way I did before, except I would do a more robust evaluation of mechanisms. And this can be done in different ways. So you can operationalize the determinant frameworks in a way that captures complexity and mechanisms. And you can also use something called the realist evaluation to better understand the mechanisms of the intervention. But I would try to start personally. I haven't seen this documented anywhere, but I would try to address mechanisms more carefully and more thoroughly than I did with the type 1, because that can really give ideas about how the intervention is unfolding and how it will play out in the real world. You know, if you go to a hybrid type 3 trial, the main aim is to ensure it's acceptable, appropriate, and feasible to monitor for this. And we secondarily look at clinical outcomes because it's already been established as clinically effective. It's still, I will add, very important to monitor for that. It's usually a quasi-experimental without a control arm. So a good example of a good quasi-experimental is an interrupted time series. And here there's strong momentum to roll it out, but full effectiveness for implementation is not being established. We want to look at how clinical effectiveness can vary by the quality of the implementation. That's important. So we can adapt that moving forward. It's more justifiable when clinical outcome data is routinely available. So sometimes health centers routinely collect information on, say, PHQ-9 scores, which are a measure of the severity of depression. Or sometimes they can collect information on chronic disease, diabetes, systolic, diastolic blood pressure that's routinely available at the clinic and recorded in the different systems. And again, I would look at what you do in the others, plus coverage is super important here. And there's a lot of different types of coverage that you can capture. And I'll leave you to look that up, but I give another lecture in my module on that one. I would look for associations between clinical and implementation outcomes in the diverse context that it's scaled up. I would look how context influence implementation strategies in the intervention in diverse settings. And I would operationalize that to look at mechanisms importantly. You can also use the realist evaluation to understand how selected implementation strategies in the intervention unfold at diverse settings. So I've seen the realist evaluation be used by someone who's quite well known for the realist evaluation, Bruno Marchal. And he's based in Antwerp at the Tropical Institute, and he has a really nice paper demonstrates how he used that to explain why an intervention was more effective in one context than another. So for a type 3 trial, if we're just based on a primary implementation outcomes, how much power do we have? That's an important consideration. Do we power for clinical or implementation outcomes? How are we going to use an evaluation outcomes framework? What is our evidence for implementation strategies? Importantly, look at the costs in the design phase, not post hoc. I would always consider doing that. And there's some nice papers out in that too, why it's important in implementation research to look at that before you pilot it or test the effectiveness. And how will you collect clinical outcome data that's not routinely available? That's it.